Greetings to all of you that are attending this session known as Understanding and Managing Pain and Fatigue in Spondyloarthritis and Psoriatic Arthritis. We are members of a variety of organizations that are noted on the bottom of this slide, including Spartan, which is a Spondyloarthritis Research and Treatment Network in the United States, GRAPPA, Group for Research and Assessment of Psoriatic Arthritis. That's an international organization. The Spondylitis Association of America, which is a patient-centered advocacy organization for spondylitis patients, and the National Psoriasis Foundation, again, a large patient-facing organization that is devoted to the cure, ultimately, of psoriatic disease. We are coming together to present a program known as CAPES, Clinician and Patient Education Series on Psoriatic Arthritis and Axial Spondyloarthritis, and this is made possible by an educational grant from Pfizer. This is the second in a series. The first was on pediatric spondyloarthritis and psoriatic arthritis. The third will be on treatment updates to bring us all up to date on various treatments. And the fourth that will be patient-facing on wellness and everything you wanted to know about diet and exercise and so forth. So if we could go to the next slide. I'm going to be starting off today's program with a pre-recorded lecture on pain, giving you a little bit of background about pain neurobiology, as well as pain as it presents in inflammatory arthritis conditions such as PSA and SpA, and then followed by a lecture by Dr. Choy, and we'll get to that in just a second. Next slide, please. So for the overall program, these are the individuals who were involved in planning this series. These are members of Spartan and GRAPPA, and their various disclosures with pharmaceutical relationships. Next slide. And these are the faculty for today's program. Minnie, as we know her, have come to know her, Minionette Wilson. I love that first name, Minnie, and her ongoing relationships. Ernest Choy, who it's now post-midnight where Ernest is coming in from in Wales, and I'll give you more of an introduction on him in just a moment. Melissa Leeolou, who is a medical student at Stanford and just coming off of a night on her OB/GYN service as a third-year medical student, but looking chipper for today's program. We'll see how she does when we get to the fatigue lecture that Ernest is giving. And then myself, and I'm a rheumatologist based in Seattle, Washington. Next slide, please. This activity has been planned according to the ACCME organization. It's accredited for continuing medical education credits, and you're eligible for 1.5 Category 1 credits by participating in this activity. Next slide. We would very much appreciate and need your evaluation in order to get your CME certification. And so there'll be various points where you'll be prompted to fill out evaluations, and also visiting this website for the full accreditation. And you can scan the QR code here with your smartphone if you want to take a picture of this slide. Next slide. Here is our agenda. I'm going through welcome and introductions as we speak. We're going to have a pre-test polling questions, then pre-recorded lectures on pain and fatigue, respectively, and then a post-polling question. We'll hear from Minnie and Melissa, respectively, about their experience as patients with psoriatic arthritis and, in Minnie's case, spondylitis. And then we'll break into a live panel discussion where we'll be fielding questions from you, the audience, and we really encourage you to put your questions into the chat so that we can address them. And we'll also be having some discussion amongst ourselves about what we're talking about today. So just before going to the first question, I do want to introduce Ernest a bit more, and Melissa and Minnie as well. So Ernest is head of rheumatology and translational research at the Division of Infection and Immunity and director of the Cardiff Regional Experimental Arthritis Treatment and Evaluation Center at Cardiff University School of Medicine in Cardiff, Wales. He also has a number of other positions of various sorts, various committees in the UK. I've known Ernest for a couple of decades now. We've shared mutual interest not only in the inflammatory rheumatic diseases, but also in particular the issue of pain and fatigue as they relate to these diseases, including not only the obvious peripheral inflammation generating pain, but also the phenomenon of central pain, which we're going to get into in a moment. Minnie is a person who is associated with the Spondylitis Association of America. She is a co-leader in support groups and has contributed a lot of time to helping patients with spondylitis over the years. She's had psoriasis since she was a young child, but didn't really get into having a full diagnosis of psoriatic arthritis and spondylitis until later in life. And she'll guide you through her own personal story in that regard. Melissa has also had psoriasis since she was a young child, psoriatic arthritis since she was a young adult. She was raised in New York, but now is living in Stanford, where she's a third-year medical student. And she's been volunteering and helping people through the National Psoriasis Foundation for about a decade. So I'm really tickled and pleased to have such a great panel today. Now, if we could go to the first question. Which of the following statements is true? Chronic widespread pain and fibromyalgia are synonymous terms. They represent the same thing. B, psoriatic arthritis patients who have concomitant fibromyalgia are less likely to achieve minimal disease activity criteria with treatment. C, studies of patients with psoriatic arthritis show that up to a third of patients have concomitant fibromyalgia. D, narcotic pain medications can be an effective treatment of fibromyalgia when used long-term. And E, fibromyalgia is best classified as a mental health disorder closely associated with depression and anxiety. Now, if you could address these questions, pick your choice. And then when ready, could we go to the next question? Question number 2 relates to Ernest's lecture. Patients with fatigue may benefit from the following treatments: A, exercise; B, cognitive behavioral therapy; C, methotrexate; D, biologics; E, all of the above; or F, G, or H, which are combinations of choices above: A and B, A, B, and C, or A, B, and D. So this first lecture is going to be focused on pain, and I am Director of Rheumatology Research at Swedish Medical Center in Providence St. Joseph Health, and clinical professor at the University of Washington School of Medicine in Seattle, Washington. I've had a long-standing interest in the diseases psoriatic arthritis and axial spondyloarthritis. starting way back in the 1980s when I first went into clinical practice, and then in the 1990s developed one of the first biologic trials using a drug known as etanercept in treatment of psoriatic arthritis. It was an independent investigator study that we conducted at our center in Seattle. And since that time, I've been very involved in not only treatment trials of various medications that are now being approved for the treatment of psoriatic arthritis and axial spondyloarthritis, but very much involved in teaching and research on the disease states. So without further ado, let's go on into the lecture, and then I will see you again at the other side of the lecture before Ernest's lecture. Hello, my name is Dr. Philip Mease, and I'm speaking about pain and psoriatic arthritis and axial spondyloarthritis, etiologic considerations, assessment, and treatment outcomes. Back in the 1600s, René Descartes had already well understood the neurophysiology of pain, depicted here in which this person's foot in the flame is signaling from the periphery into the brain. Now we have a much more sophisticated understanding of this process, very complicated, in which there is both peripheral and central sensory processing influenced by many factors, including genetics, the pain and coping behaviors of the individual, the immune system, and other factors. Here are depicted in a simplistic way the pain pathways. A painful stimulus is noted, for example, passing your finger through a flame, and a signal is sent through the spinal cord up into the cortex and insula. And this is facilitated by a number of neuropeptides, such as NMDA glutamate, substance P, and nitric oxide. But simultaneously, there's an inhibitory pathway, or descending, which includes neuropeptides such as norepinephrine, serotonin, GABA, opioids, cannabinoids, which modify and influence this pain experience. It's important to have a balance between these two, and we know that in certain situations like central sensitization, there is an excess of the ascending pathway and a deficiency of the descending pathway. We now have a more sophisticated knowledge about various receptors and neurochemicals which influence our experience of pain at a peripheral level and at a central level. And there are many factors that influence and modulate our pain experience via the transmission of nociceptive signaling. Here's an example of a device that's used in pain research, in which a researcher applies a certain amount of pressure to a thumb. I call this the thumb smasher. Here's an example of work done in which a normal individual is given a stimulus intensity on the lower left side of this graph. And you see that the pain intensity is not very much. But as you double the amount of pressure that's put on the thumb, then the patient actually records it as being quite painful and shows light up in appropriate places in the brain where pain neuroprocessing is occurring. We're going to get into fibromyalgia more in a moment, but as you can see here, a patient with fibromyalgia, you just have to apply a bit of the pressure, and they will experience pain not only subjectively, but also will light up in the same areas of the brain where the normal patient with more pressure lights up. So this is like a lie detector test that really tells us that the fibro patient is experiencing this pain. Pain is the primary complaint
in rheumatologic and musculoskeletal disease. And here's a short list of some of the conditions for which pain is paramount. And it's very important for us to try to control pain for this patient to have a improved quality of life and function. Psoriatic arthritis, in the inner circle here, you see pain listed as one of the core items that needs to be assessed in clinical trials and hopefully improved with treatment. Here we see the ranking of psoriatic arthritis patient focus groups conducted in Seattle, Cleveland, and Washington, D.C., led by a medical anthropologist. And as you can see, pain, which is the fifth bar down on the patient side, as well as on the physician side, is ranked very highly as an important part of the PSA experience. Here we see the axial spondyloarthritis core set. And again, we see that in all trials, pain should be assessed. However, in this report of the American College of Rheumatology Pain Management Task Force, it was discovered that many rheumatologists are uncomfortable treating pain, partly because of bad experience with use of narcotic pain medications. Most were not taught how to evaluate or manage pain during training, and most of the time, their approach to treating pain is by concentrating on treatment of reduction of inflammation. Here are a few of the ways in which we measure pain in clinical trials and practice. Probably the simplest is either a visual analog scale or numeric rating scale, the latter being a number from 0 to 10, the former being either from 0 to 100 linear scale or 0 to 100. And then there are other considerations like anchors on either end of this scale, from no pain at all to the worst possible pain that you could imagine. The time span of assessment: should you assess how the pain is right now, over the last 24 hours, over the last week, over the last month? As it turns out, the FDA prefers assessment of average pain over the course of the week. There are also a number of composite measures, for example, the brief pain inventory or the PROMIS pain interference and intensity scales. These ask several questions to get more at the multidimensional nature of pain. Here's an example of a pain assessment and treatment in a recent psoriatic arthritis study using a JAK and TYK2 inhibitor known as brepocitinib. In this case, I've circled the baseline patient assessment of pain based on a VAS scale of 0 to 100. And as typical for many such trials, it's about just shy of 60. And then here we see what happens during the course of treatment, first at week 16 and then out to week 52, showing improvement of pain happening fairly rapidly in the colored brepocitinib treatment arms versus placebo in gray. That also you see the improvement of the fatigue scale. Here's another example showing pain response in use of an IL-17 inhibitor known as ixekizumab in both psoriatic arthritis and axial spondyloarthritis trials, showing improvement compared to placebo in measures such as joint pain, as well as in the psoriatic arthritis patients, spine pain and spine pain at night, which is a characteristic feature of axial spondyloarthritis in the axial SpA patients. And then also there's another measure, the quality of life measure SF36. And here we're looking at the bodily pain domain score improvement. Interestingly, we've been doing some further analyses of pain response in some recent trials. Here's an example from the tofacitinib phase 3 trials in psoriatic arthritis. And we did a sophisticated statistical methodology known as mediation analysis and asked the question, how much of the pain improvement that we're seeing is due to a direct effect of tofacitinib on pain reduction versus what we would call an indirect effect through improvement of inflammation, as reflected in the CRP and swollen joint count. And it turned out in this analysis that 74% of the pain relief was due to a direct effect of tofacitinib, raising interesting points about the potential for this particular mechanism of action to influence both peripheral and central nociception, and not just through improvement of inflammation. Now I'm going to turn to talking a bit more about some confounding issues that influence our assessment of pain and our thoughts about the ability to achieve certain goals of treatment. So I'm going to be talking about a phenomenon known as central sensitization, in which a patient may have increased sensitivity to pain, and a new term that's called nociplastic pain. We're also going to be talking about this phenomenon called chronic widespread pain and fibromyalgia. Chronic widespread pain is focused on just the experience of pain, whereas fibromyalgia includes a broader set of issues, including fatigue, sleep disturbance, dyscognition, and other somatic symptoms. Bringing us back to this study done by Rick Raisley, again, we see that in this case, the patient in the upper left of the graph, the red triangle, who has fibromyalgia with only a modest stimulus intensity, the pressure on the thumb, is showing significant pain intensity and light up in the parts of the brain where pain processing should be occurring. Thus, this patient is truly experiencing this level of pain, even with a minor stimulus. We now know more about this. Here's a quite sophisticated study looking at brain neurophysiology, in which it was shown that several important neural networks in the brain had increased activity, the default mode network and the executive attention network, on a continuous basis in fibromyalgia patients. And this supports the theory that there is increased central sensitization due to changes in neuropeptide function and neural connectivity in patients with fibromyalgia. We also are learning that there is a genetic underpinning to this. In this work from the University of North Carolina, we see that there are a number of different genes that are involved in the pain experience. And so if a person happens to have certain genes, for example, the COMT gene, certain alleles, that they're more likely later in life to experience not only fibromyalgia, but the whole range of central sensitization. And this is influenced by a number of factors, including psychosocial factors like anxiety and depression. That has to do with how one was raised, whether you had abuse in the home. It also is influenced by tissue injury and persistent immunologic inflammation, for example. And all of these factors contribute to increased pain sensitivity. Here is a table which shows that regardless of the autoimmune disease in question, there is a higher prevalence of fibromyalgia than is typically seen in a normal population, where we typically see somewhere around 2 to 4% of the population having fibromyalgia. I usually tell patients that it's somewhere in the 20% range, 15 to 20% range of patients with these diseases that have concomitant fibromyalgia. And this is influenced by not only their genetics, but also the ongoing inflammation and pain in peripheral sites. Here are some of the assessments that we do for fibromyalgia, starting with the older 1990 fibromyalgia criteria, and then more recently, the Chronic Widespread Pain Index and Symptom Severity Scale developed by Fred Wolf and others, the Pain Detect Questionnaire, the FIRST questionnaire, the Central Sensitization Index, and so on. Also, there are some more objective measures, not practical for clinical practice, but done in research, including quantitative sensory testing and neuroimaging, such as functional magnetic resonance imaging. Here's an example of a diagram from the Widespread Pain Index article, in which we're looking at whether the patient is experiencing pain in multiple parts of the body, and the more parts of the body they are experiencing pain, the more likely they have chronic widespread pain and fibromyalgia. And then added to that is the symptom severity scale, in which there is scoring for symptoms such as fatigue, sleep disturbance, cognitive dysfunction, and several other somatic symptoms like headache, abdominal pain, and depression. And then a scoring system that's listed down below. Here's as yet unpublished data from the core Evitas Psoriatic Arthritis Registry that I am involved with, in which we're looking at, on the left-hand side of the scale, a DAPSA score, which is a disease activity measure, and on the x-axis, a fibromyalgia severity scale. And as you can see, there's a continuum. It's not a discrete yes or no, the patient has fibromyalgia. And it turns out that on this scale, anything above 12 is correlated with having fibromyalgia. I call this the scale of fibromyalgia-ness. And a person can be over on the right-hand side of this scale much of the time, and then they have definite fibromyalgia, or go in and out, depending upon a number of factors, including disease control. As you can see in this study on rheumatoid arthritis, as an example, we see that in the measures that have subjective elements, with such as the DAS-28 or patient global assessment or tender joint count, we see a much higher score for these disease activity measures than in a patient with rheumatoid and fibromyalgia than a patient with rheumatoid alone. Whereas the more objective markers, such as the swollen joint count, the CRP, or in this case, a vector score, there wasn't a difference. So it makes the point that when you're evaluating a patient with a disease like rheumatoid arthritis, and they also show signs of having concomitant fibromyalgia, then you can trust more the more objective aspects of their measurement of disease. Here is a similar type of study in psoriatic arthritis. In this case, in Israel, this cohort of patients, 18% of them had concomitant fibromyalgia. And again, you see the same lesson, and that is that all the measures that have some subjective element to them were almost twice as severe in the patients with concomitant fibromyalgia. Whereas measures like the CRP or the skin evaluation, which are more objective, did not show those differences. And then importantly, in the middle there, MDA achievement, minimal disease activity achievement, was achieved by nearly half of the patient with treatment of their psoriatic arthritis, but none of the patients with concomitant fibromyalgia. So we can see that treating to target is more difficult in such patients. Here's another study done in Denmark, in which a group of patients were being treated are starting treatment for their psoriatic arthritis. They had a number of evaluations, both clinical, ultrasound, questionnaires, including a widespread pain index. And it was found that a third of the patients were identified as having chronic widespread pain at baseline. And in those patients, none of them were able to achieve minimal disease activity versus 20% of those that did not have fibromyalgia. And there was no correlation with ultrasound. Turning to axial spondyloarthritis, here we see a study that was done in Brazil, ankylosing spondylitis patients. Again, a similar proportion of patients, so slightly less than 20%, that had concomitant fibromyalgia. And again, we see the same phenomenon that in these measures, which include subjective elements, the patients graded themselves much more severely when they had concomitant FM. A study from Cleveland showing the same thing, in which patients with concomitant fibromyalgia and ankylosing spondylitis had much worse assessments than patients without fibromyalgia. And then finally, I want to show you an example of a very interesting study done in France, in which a large number of patients were initiating anti-TNF treatment who had axial spondyloarthritis. And we're looking here at use of the first questionnaire to identify people who had fibromyalgia concomitantly. And at baseline, 31% of the patients answered positively on this questionnaire, having fibromyalgia. Treatment was done, and at month 3, we can see that significantly more patients who did not have concomitant fibromyalgia were able to achieve an ASDAS, low disease activity or remission score, than patients that had concomitant fibromyalgia. But very interestingly, when the fibromyalgia questionnaire was again applied to these patients at 3 months, 18% rather than 31% answered positively, raising the possibility that by effectively treating the patient's underlying disease, that one can modulate the central sensitization or fibromyalgia experience. So in summary, we've learned that pain is a cardinal feature of rheumatic disease, including psoriatic arthritis and axial spondyloarthritis, impacting function and quality of life. The neurobiology of chronic pain is complex, involving both peripheral and central nociception, influenced by genetic and environmental and sociocultural factors. Pain assessment and treatment is important for patients and clinicians. And concomitant fibromyalgia or nociplastic pain and central sensitization influence assessment and outcomes and should be taken into account in shared decision-making about disease treatment with your patients. Thank you.
Thank you. Welcome back to the live portion of the program. And although we're going to segue right away into a discourse by Ernest Choy, entitled A Brief History of Fatigue and Inflammatory Arthritis, and he's going to focus on the symptom area of fatigue. Thank you, Ernest.
Hello, I'm Ernest Choy. I'm Professor of Rheumatology at Cardiff University, and I'm grateful for GRAPPA for inviting me to give this talk about fatigue in inflammatory arthritis. What I will try to cover during this talk is why fatigue has become a core outcome in rheumatic diseases, including psoriatic arthritis, what may cause fatigue, how to assess fatigue, and then how to treat fatigue. So at the start, fatigue first became prominent in the mindset of researchers in rheumatic diseases from the beginning of this century, when the outcome measure in rheumatology groups start to engage patient and put patient at the center of the research agenda. And one thing that became clear during discussion with patient is that fatigue is very disabling, and patient wanted to be addressed assessed and treatment to be developed for fatigue with inflammatory arthritis. So as a result of that, the group recommended that fatigue should be measured in clinical trials and clinical studies of rheumatoid arthritis whenever it's possible. When fatigue is measured in rheumatoid arthritis, an instrument that has been validated in rheumatoid arthritis should be used. Additional studies should be undertaken to define an optimal fatigue instrument in rheumatoid arthritis, and the group supported a research agenda aimed at understanding fatigue in rheumatoid arthritis and the development of therapeutic intervention. So this is the first time when fatigue becomes center stage of the research agenda. But since the inclusion of fatigue in the core outcome set of rheumatoid arthritis in almost every single rheumatic diseases, we are starting to see fatigue being center to the disease assessment, and that included psoriatic arthritis. Now, as rheumatologists, we don't really study fatigue, and we had to learn from other specialty. And one specialty that has looked at fatigue intensely are the neurologists. And this is a review paper published in The Lancet in 2004. And you can see that the neurologists are identifying potential mechanisms that cause fatigue in different rheumatic diseases. And they categorize fatigue into those that is peripheral. So, for example, driven by muscle wasting or muscle weakness, and those that are central, mechanisms that impact on the spinal cord and brain. And both of them can contribute to fatigue. But regardless of whether it's peripheral or central fatigue, in this study in rheumatoid arthritis, what you can see is that either type of fatigue tend to impact on the patient's quality of life as measured by the domains of the short form 36 questionnaire. So fatigue, as the patients tell us, and research has now confirmed, it is impacting on patients' quality of life. Now, what may cause fatigue in inflammatory arthritis? We considered this a number of years ago, and we thought that there are many potential causes. This includes concomitant diseases like depression or fibromyalgia, perhaps inflammation and cytokines such as TNF, IL-1, and IL-6, maybe the hormonal distress, the hypothalamic pituitary adrenal axis, chronic pain itself. It may be metabolic. For example, anemia is common in patients with rheumatoid arthritis. Of course, many patients with inflammatory arthritis have muscle wasting, and also some medication may well cause fatigue. So we started to conduct a study looking to give us some indication as what may be causing fatigue in rheumatoid arthritis at the time of OMRAC. So this was published in Rheumatology Oxford in 2006. In this study, we assessed fatigue in patients with rheumatoid arthritis, both in a cross-sectional study, but also in a study before and after patients were treated with standard conventional synthetic disease-modifying drugs, but also TNF inhibitors. And first of all, what you notice here is that as the patient have told us, many patients suffered very significant fatigue. So you look at the percentage of patients who have a VAS fatigue score of at least 50 millimeters out of 100, you can see that more than half the patients suffer from high fatigue. And in fact, the proportion is higher with patients who are treated with conventional synthetic disease-modifying drugs, and even more so in patients treated with a TNF inhibitor. And if you look at the absolute mean fatigue score, again, the mean fatigue score is almost 50 at 49. And again, in patients just started on treatment with conventional synthetic DMARDs and TNF inhibitors, the score are even higher. What was interesting in this study is that when we try to correlate the fatigue severity using a VAS score with disease activity as measured by the DAS28, there is a significant correlation. But in fact, the correlation is lower than the pain score, suggesting that pain and fatigue are strongly related to one another. We also, during this study, excluded a number of potential factors that may be causing fatigue. This includes age, gender, rheumatoid factor, nodule, disease duration, steroids, codeine-containing treatments, leflunomide, antimalarial, sulfasalazine, gold, azathioprine, cyclosporin, and D-penicillamine. Concomitant disease like diabetes, respiratory diseases, hypothyroidism, and ischemic heart disease were also not contributing to fatigue. In addition, neither hemoglobin or creatinine level were correlated with fatigue in rheumatoid arthritis. The variables that correlated with fatigue and associated with fatigue are listed on this slide. It includes pain, the degree of disability, erosive disease, concomitant methotrexate as treatment, a diagnosis of depression, and also disease activity. In totality, these factors attribute to just over 50% of the fatigue score, but it also means that there is a significant degree of fatigue which are not currently captured by this study. So there are other factors that may be contributing to fatigue. Now, this kind of result has been replicated in psoriatic arthritis, and I listed a study here looking at the occurrence of fatigue in patients with psoriatic arthritis. These are the univariate analysis result, again showing a strong correlation with pain, mental health, HAC, methotrexate, as well as fibromyalgic tendon points. So in many ways, the fatigue in psoriatic arthritis are very, very similar to what we see in patients with rheumatoid arthritis. Now, based on this observations, the OMRAC-RA fatigue group drew out this diagram to illustrate fatigue in rheumatoid arthritis, but I think this is also applicable to psoriatic arthritis in that the cause of fatigue in inflammatory arthritis is multifactorial. There is one element on the top left-hand side of this slide, which is related to the disease, related to inflammation, the pain, and the anemia, and the drugs that patients take. On the right-hand side, there are certain cognitive behavioral elements to fatigue. So this is reflected by the presence or absence of depression or anxiety. And also, what we have shown in this study is that fatigue is strongly associated with physical disability, be it in psoriatic arthritis or rheumatoid arthritis. High fatigue score is always associated with high level of disability. So how do we measure fatigue? Well, there are two main categories of instruments that has been used to assess fatigue in inflammatory arthritis. I've listed this on this slide. These are the VAS fatigue score. Sometimes it can also be measured by a numeric rating scale. The FACIT-F score is commonly used in clinical trials of psoriatic arthritis as well as rheumatoid arthritis. There's also the fatigue severity scale. PROMIS has a specific fatigue domain. And then there is an instrument that has been developed in other diseases that is called multidimensional fatigue inventory. And this differs from the other in that this is a multi-dimensional fatigue measurement. It measures different aspects of fatigue. For the other, in the main, they're capturing the severity of the fatigue. Now, until very recently, we have to rely on this instrument because there were no instrument that has been specifically developed for inflammatory arthritis. This changes with the publication of the Bristol Rheumatoid Arthritis Fatigue Instrument. And there are two forms. One is a multi-dimensional instrument called the BRAF MDQ, but you can also use a version that is a unit-dimensional tool called the BRAF VAS or numeric rating scale. And these instruments have been fully validated for rheumatoid arthritis. In the multi-dimensional questionnaire, it assessed 4 different domains of fatigue: the physical element of fatigue, how patients live with fatigue, the impact of fatigue on cognition, and also the impact of fatigue on emotion. For the breath VAS and numeric rating scale, is a unit-dimensional instrument, and it aims to assess the severity of the fatigue. Which instrument you choose to use depending on what you want to assess in the clinical study. So if you only want to see a treatment and assess its ability to reduce fatigue, you can use a unit-dimensional instrument. But if you want to use an instrument that has looked at specific impact of fatigue and the ability of a certain intervention to improve fatigue, then the breath MDQ would be appropriate. And in fact, the breath questionnaire has been validated in psoriatic arthritis too. This is a study from Toronto looking at using the breath instrument in patients with psoriatic arthritis. And you can see on this slide, the breath instrument correlated very well with disease severity, with physical disability, as well as the Charleston comorbidity impact. So important to patient is how to treat fatigue. And the OMRAC group who drive the incorporation of fatigue in rheumatoid arthritis then led the development of 2 Cochrane systematic review on which interventions may be effective for reducing fatigue. One group that looked at non-pharmacological intervention, another that looked at biologic treatment for reducing fatigue in rheumatoid arthritis. Started off with the biologic intervention first, because that was the study that I was more intensely contributed to. This is the forest plot of all the biologic study that were included in the study, and it conclusively showed that biological intervention reduce fatigue in rheumatoid arthritis, as shown by the position of the diamond at the bottom of this slide. In this study, it subdivided the biologics into TNF inhibitors and non-TNF inhibitors. And you can see by the position of the diamond on this slide that, in fact, the reduction of fatigue with TNF inhibitors is very similar to the reduction of fatigue with non-TNF inhibitors. And putting this into numbers for you, you can see that the reduction of fatigue associated with TNF inhibitors is roughly equal to about 6 units on the FACIT-F scale. And for the non-TNF inhibitors, the reduction is equivalent to 6.9 units on the FACIT-F score. So this study conclusively showed that fatigue can be reduced by biologic agents in rheumatoid arthritis. However, importantly, this study also shows that fatigue don't go away. The level of energy do not recover to normal range. So biologics reduce fatigue, but there is also some fatigue left in many patients, suggesting, therefore, that there are elements of fatigue that is not driven by inflammation and cytokine. But it also shows that inflammation and cytokine contribute to a degree of fatigue in our patients. Now, although systematic review in psoriatic arthritis hasn't been performed, but there are reports of biologics reducing fatigue in psoriatic arthritis. This is just one of those studies using the FACIT-F questionnaire. It shows that before and after treatment, biologics reduce fatigue in patients with psoriatic arthritis. Interestingly, in this study, it also looked at the result using a mediation analysis. And what a mediation analysis is attempting to do is that they are hypothesizing that a particular treatment, in this case a biologic, has reduce fatigue in our patients. At least one explanation of why these patients have reduction in fatigue is due to reduction in inflammation, and you use the measure of inflammation in the study, such as the ACR20 response rate, and say that if the exposure, the treatment, reduce fatigue completely by inflammation, we will see a major impact and contribution of this reduction in fatigue due to changes in the inflammation measure. But having adjusted and captured all the changes through inflammation, any residual effect might have been due to a more direct effect on the treatment on fatigue. And so in this mediation analysis, what they tried to show was that there is some reduction in fatigue that cannot be explained by simply reduction in inflammation. So the biologics may well have additional effect in reducing fatigue in patients with psoriatic arthritis, but exactly how it managed to achieve so is something that needs to be investigated further. For non-pharmacological interventions, the Cochrane review shows that there were 2 interventions that show promise. One is physical activity. The other is psychosocial intervention, and in most cases, some form of cognitive behavioral therapy. And they show both reasonable number needed to treat, 7 for physical activity and 10 for psychosocial intervention. And in fact, the latter were tested in a large randomized placebo-controlled study called the RAF study. And in this study, a healthcare professional were trained to deliver cognitive behavioral therapy, and these were delivered to patients who have stable rheumatoid arthritis but have significant fatigue when they were recruited into the study. And the aim of this study is to look at whether cognitive behavioral therapy delivered by healthcare individuals can reduce fatigue in patients with rheumatoid arthritis. And this is the result, showing that patients who receive cognitive behavioral therapy show much less impact from fatigue compared to patients who were managed by standard advice and treatment. So we suggested that, again, confirming that cognitive behavioral therapy as a form of psychosocial intervention is able to reduce the impact of fatigue in patients with rheumatoid arthritis. But I suspect this will not be unique to rheumatoid arthritis, but will be applicable to psoriatic arthritis patients. But I think those intervention research did add weight to what we said at the beginning, which is fatigue in inflammatory arthritis is likely to be multifactorial. There are elements that are driven by inflammation, and we know that treatment that reduce inflammation, such as a biologic treatment, is able to reduce fatigue, although they don't return to complete normality. And that's really because there are elements of fatigue that are driven by psychosocial element, by cognitive behavioral elements, and this aspect of fatigue can be impacted by psychosocial intervention, such as cognitive behavioral therapy. So the two together may well be additive in terms of reducing the impact of fatigue on disability. Last but not least, let me wrap up by saying that outside the world of rheumatology, in neurology, going back to the beginning, a systematic review of more than 92 studies in neurological condition has started to decipher what may be causing central fatigue in patients with neurological condition, and mainly multiple sclerosis. And it demonstrated there are functional and connectivity dysfunction in the central nervous system in different regions of the brain, particularly the frontal, parietal, occipital, temporal cortex, and the cerebellum. And these shows that there is a definitive biologic functional element to the causation of central fatigue. And understanding exactly what contributes to central fatigue may help us to develop specific treatment in the future. And there are groups in the world that are trying to use the same type of methodology in neurology, in rheumatic diseases, to try to decipher the precise mechanism. So in summary, fatigue is a subjective symptom of malaise and aversion to activity, compromising both physical and mental aspects. Fatigue has multiple etiology, but at least partly related to neuroimmunological effect of autoimmune disease in the central nervous system. Fatigue as part of the core domain set for rheumatoid arthritis grew from patient group at OMRAC 2002 and adopted in 2006 and now expanded to many rheumatic diseases, including psoriatic arthritis. Fatigue is often assessed by unit dimensional measures in randomized controlled trials, such as the FACIT-F, numeric rating scales, or SF-36 vitality score. The BREF MGQ is a multi-dimensional PRO validated in rheumatoid and psoriatic arthritis and may be useful for research, while the numeric rating scale of the BREF is a unit dimensional measure that can be used in everyday practice. Biologic, exercise, and cognitive behavioral therapy can reduce fatigue in inflammatory arthritis. Thank you very much for your attention. I look forward to discussing this with you further.
Greetings and welcome back to the live portion of our program. We're going to first have the post-test questioning, and so if we could bring that up. The first question was, again, going through these, which of the following statements is true? I'm not going to read them each, but if you could read them through them yourselves again, and based on the lecture, see what your responses are. Okay, and will I get a chance to see these responses, or we come back to that? Okay, so here we go. I'm getting some numbers here. So it seems that B, okay, so I'm glad you all were clearly listening. B wins out with 83% responding as that is the choice, and that is exactly correct. In numerous studies that we showed, the patients who had concomitant fibromyalgia along with their primary disease, had less likelihood to achieve a target of therapy known as minimal disease activity. The other that got some responses was A, chronic widespread pain and fibromyalgia are synonymous terms. Just to explain that a little bit more, so CWP is really focused on the pain aspects, whereas fibromyalgia is a broader concept that includes, for example, fatigue, sleep disturbance, cognitive cloudiness, other somatic symptoms. So you're going to have generally a larger number of people that have fulfilled the criteria for having chronic widespread pain, including hyperalgesia and allodynia, in say a third to 40% of patients, whereas fibro is going to be more likely to be involving 18 to 20% of patients. Let's go to the second question. Patients with fatigue may benefit from the following treatments. So there's a list here, and then also some multiple choices down here. If you could respond, that'd be great. And whenever you all have finished voting, if we could bring up the responses and and perhaps show the correct answer, if you will, please. So the correct answer is A, B, and D. Exercise, cognitive behavioral therapy, and biologics. Notice that methotrexate was not included here, and many of us who are clinically experienced know about the methotrexate blahs that some patients get. There's a feeling of fatigue, nausea, et cetera, that can sometimes be associated with that therapy, oftentimes only on the day of or day after the treatment, but sometimes extending through the week. Okay, so what I'd like to do now is segue to hearing from our two patients. And we're going to start with Minnie, as she's known, who comes to us from North Carolina and has been experiencing psoriasis, psoriatic arthritis manifestations, and spondylitis manifestations. And she's going to give you a little background on her therapy and any other comments she may have about the general topic of pain and fatigue. Minnie?
Thank you, Dr. Mease. I would like to share a little bit about my journey with psoriasis and psoriatic arthritis. I have pretty much had symptoms since birth, and you just don't know how to handle it at first. I think during the early years, there was such little research available that I had to figure out a lot of things on my own. But over time, as the pain increased and eventually leading to a diagnosis, I had to get to a different place and get to a point that I started understanding my disease a lot better so that I could manage it better. And it also helped having a good team. I can definitely resonate with the research experiences that Dr. Mease and Dr. Choy shared with us, and my need for biologics and exercise tremendously helped my fatigue. And so I've learned that without a biologic, I do have much higher levels of fatigue, and it's a continuous struggle. And so being when I'm on biologics, I'm able to exercise more and there's less fatigue. I've also learned through the years that I needed a number of natural supplements that target inflammation and other things in my body that have helped me be able to just feel better. And my fatigue is in a much better place than it's been in previous years. I'm able to make it through the day without that need for a nap, because there were times when I felt like I could really, and I did, just go to sleep anywhere at any time, just having to just get that power nap to be able to make it through to the next thing. I think that cognitive behavioral therapy has been essential to my journey. I had to take that when the headache started from the spondyloarthritis in my 40s, and I was able to take those techniques and use them to help me manage my pain and be able to have a different perspective on functioning each day. And so changing my mindset, instead of worrying about the future or tomorrow, I focused more on getting through that current moment. I was not as overwhelmed, and my pain and fatigue were better managed, and things were a lot better. So I think that the research that they have been doing has everything to do with my experience as a patient. And I'm glad that we are moving forward with this research. And back to you, Dr. Mease.
Thank you very much, Minnie. And now, Melissa, if you could share your story and some of your comments on this topic.
Thank you so much. Hi, everyone. My name is Melissa Leeolou, and I'm so excited to be speaking with you all today on topics that have been just so important in my life. When I think about my psoriatic disease management, pain has definitely been a focus from the start. But that's not to say that fatigue isn't a significant problem, because it definitely is. But for me, the general symptoms that I feel from psoriatic arthritis are essentially the classic symptoms: stiffness, pain, throbbing, tenderness in the joints, and a decreased range of motion. So quite simply, my joints just feel like they get stuck in one place where it hurts to move. And some days it can feel almost impossible just to sit myself up and get out of bed. But one reason why pain has been my primary treatment focus thus far is that when we as patients describe our disease to physicians, it can feel really challenging to put the experience into words. But pain is fairly easy to understand because, we've all felt it in some way before, and it's a very clear deviation from good health. But on the other hand, when my disease is not being pharmacologically managed, I could actually sleep for more than 10 hours, wake up tired, and have my body ready to collapse by maybe 2 p.m. in the afternoon. And while in those moments I find it difficult to concentrate or function, I still feel in some ways very judged by others who can't help but rightly think to themselves, well, I'm tired too. And because not everyone lives with pain every day, but many or most people experience some version of fatigue regularly. And this builds up and creates a stigma around fatigue, leading to communication barriers. So just because I'm not presenting to my doctor with a chief complaint of fatigue, it doesn't mean that I don't experience it in a really significant way. And there are other problematic communication barriers that exist too. Dr. Mease and Dr. Choy in their lectures spoke about pain assessments in clinical trials and in practice. And I think it's so important to talk about the way we assess and scale pain. But I would like to add to that what I've learned to be clinically useful as a medical student does not necessarily align with how I feel understood as a patient. For example, I can't even begin to tell you how many times I've been handed a patient survey asking me to rank my symptoms or list them in order of how problematic each one is. And maybe as a clinician, these are good treatment goals and good tools. But as a patient, I don't know how to separate out my symptoms all the time. So for example, I really don't know if I'm tired because I'm in pain all the time, or if my fatigue is a symptom of its own. Now, I definitely don't have to be the one to tell you all that doctors are very busy, to say the least. But I want to say that what might just be a 15-minute block in your day is often very eventful for a patient. Sometimes you're waiting months just to see you for that visit, that small window of time. And I've emphasized a little bit the importance of communication, because what happens in a patient-provider visit during that short time has really significant implications for how patients view themselves, view their disease, and ultimately, in some ways, whether or not they feel empowered to take action for their disease management outside of that clinic visit. And so with that in mind, the last message I'd like to reflect on is the emotional impact of chronic pain and fatigue. The pain and fatigue can be cyclical. So while I have good days, I also have bad ones, and the inability to predict my state of health can feel very anxiety producing. And unlike psoriasis, which is unfortunately visually apparent for everyone to see, having psoriatic arthritis is invisible. So on the outside, I look young and healthy, and I find that I have a really hard time convincing others that I even have this diagnosis. And like most patients, I also feel concerns about my future because, as we know, the disease can be progressive. So with all of that said, I'm very excited for new research and investigations that are interrogating the relationships between pain and fatigue, particularly in the context of joint disease and chronic pain. Because I think as we learn more about what's happening within our bodies in a scientific way, it'll be more targetable with treatments, and there will be more awareness about fatigue in patients like me. Thank you. Back to you, Dr. Mease.
Thank you so much, Melissa. You really touched on some important points for us. I do want to, what I'm going to do is, before opening up to a general panel discussion, I want to bring up a couple of questions that have already appeared in the chat, and then and hopefully encourage others to put more questions in the chat if you would like to. So this first question from Ariel Macedo, she's commenting on patients that are being treated and apparently being treated adequately, in that they no longer have synovial swelling and swelling of their joints, say in the hands and wrist, and importantly, their ultrasound is negative, but they continue to have tender joints. in those areas. But when she assesses them for the sort of generalized fibro picture, pressing on tender points in various places and listening for sleep disturbance and so forth, they don't fulfill that criteria either. So she's wondering, do these patients represent ongoing subclinical inflammation that's not being picked up by ultrasound, that might be causing peripheral pain sensitization still, despite the treatments that the patients are on, or could it be somewhere in between? So I think it's a great question, and we do see this where a patient has gotten into treatment. We've largely conquered the issue of swelling, but still have pain there. We'll call it residual pain. Ernest, I'm going to throw it to you first to see if you have any comments about this particular presentation.
Yeah, that is a great question. And I guess one of the problem with or limitation of ultrasound is that we can only do ultrasound on certain peripheral joints, mainly in the wrists and the hands. If particularly we do it in the absolute clinical setting, you can't perform the ultrasound scan on every single joint. And that's one of the limitations of that imaging modality. And as you said, it is therefore possible that we may be missing some subclinical inflammation. And there are researchers who are actually using radionucleotide that are linked to different kind of cytokine or vascular molecule to see whether it's possible to image the whole body for all the synovial joint to ensure that we don't miss any inflammation.
I also would bring us back to the one slide that I showed from the Corevitas registry, where there was a linear sort of line, where the patients had an increasing degree of what I called fibromyalgia. And I think that it's so that there are a lot of people who at one time or another may fall on the upper side of this line, but much of the time may spin below, but have some degree of central sensitization going on that is not the full-blown fibromyalgia picture. Would that lead us to using the types of medications that are approved for central sensitization and fibromyalgia, like the SNRI medications, duloxetine being an example, or pregabalin or gabapentin, which are these work on, if you recall, the ascending pain pathway and the descending inhibitory pathway. These work in both sides of that pathway, and could potentially be helpful. So we do use some of that. In terms of getting at residual inflammation that's not being picked up by ultrasound, that's tougher. In rheumatoid arthritis, we use the vector score to a certain extent for that purpose, to look at whether or not there's some degree of biomarker activity that's suggesting ongoing rheumatoid inflammation, even if we can't pick it up by ultrasound. But we don't have such a test in psoriatic arthritis or axial spondyloarthritis. We need that in order to better assess how much of this pain is due to some residual inflammation versus not. So Ariel, I'm not sure that we adequately addressed your question, but I think it could be on both sides. It could be some persistent inflammation, but it also could be a degree of central sensitization that hasn't flipped over all the way to fibromyalgia.
So
Ariel,
can I just add
yes,
one point?
Please do.
As you were talking about fibromyalgia and tender point, one thing we always recognize is that there is a definitive difference in sex ratio. So men are far less likely to have positive tender points. So that, in fact, that's why tender points was removed from the more recent versions of the fibromyalgia questionnaire, because it tends to underestimate fibromyalgia in men. So you cannot rely on tender points, particularly in men, to diagnose fibromyalgia.
So Ariel's come through with a second question, which is she's has the assumption or the impression that JAK inhibitors are slightly better than TNF inhibitors in controlling pain in rheumatoid arthritis. I'm going to end up throwing this one to you as well, Ernest, to start off with. She's wondering whether or not we have any similar data that can support one or the other being slightly better than the other in terms of pain and psoriatic arthritis.
I don't know whether this has been done in psoriatic arthritis, but in rheumatoid arthritis, there are head-to-head trials between Janus kinase inhibitors and TNF inhibitors, and using a path analysis, which is similar in kind, not absolutely the same as the mediation analysis. Study led by Peter Taylor has shown that, for example, the Janus kinase inhibitor tend to have more direct effect on pain than adalimumab, which was the TNF inhibitor used in that study. And there are several reviews that have been involved in trying to explain why that may be so. And I guess one potential explanation is that one cytokine that is particularly involved in nociception is GM-CSF. And Janus kinase inhibitor, by inhibiting JAK2, would inhibit GM-CSF.
Interesting. Okay. So there has been some work from using data from the OPAL studies in psoriatic arthritis with tofacitinib along the lines that you've just described. But we don't have a comparison with the TNF inhibitor, so I'm not able to speak to the comparative effectiveness. But one of the things that came out of the study with in the OPAL data was that it appeared that there was a close correlation between improvement in pain and improvement in itch. And it raised the question, is some of the pain signaling going through itch neurologic networks to the central nervous system, and that maybe there's a crossover here in the psoriatic arthritis patient where we've got some effect from the JAK inhibitors in that pathway, as well as reducing inflammation, as well as inhibiting central function. Fascinating things to think about. I'm curious, Melissa or Minnie, what your comment, since I brought up itch, what you would say about itch in relation to pain in terms of your psoriasis. Melissa, you're muted, so if you okay, great. You want to? It looks like you got
I'm happy to talk about it. Definitely. Well, as I mentioned before, when I talk about kind of surveys and like weighing which symptoms are worse or what is kind of, interacting with another symptom, I think itch and pain are often really intertwined. They are different entities, I think, from the way that it feels as a patient. But, often when you think about psoriasis and lesions, if you didn't have the rash, would you have the pain, the hot, temperature of the skin, the itch, the dryness, all of those things? And so, do you say that pain is your primary problem or that the rash is? And it's one of those things that's really hard to kind of tease apart. So I apologize for not giving a better answer to that. I think you can definitely have one without the other, though, if that's at all helpful.
Mm-hmm. And Minnie, you were nodding your head there.
Oh, absolutely, because it is exactly that way. And there are times when you think it is the pain that is the worst. And then there are times when it's the itch you just can't get it under control. So you feel like it's the itch at that moment. So it's hard to measure it, and it does change throughout the course of the rash. So there isn't a way to really be specific that one is greater than the other.
I am curious of both Melissa and Minnie, if you could comment on the style and content of the conversation that you have had with your clinicians about fatigue. So style and content, if you could think about those two words, how you would respond to that question.
I have given different explanations, but I've tried to say it in a way that they could personally relate. So one of the ways that I've explained it, because typically when I'm extremely fatigued, I'm still very achy. as well. So I've explained it as feeling like the day after moving. But when it's even worse than that, it's the day after moving and someone pushed me down a flight of stairs and I got up and came to the doctor. So that is the way that I've explained it, in a way that I feel like anyone could relate to. And that typically helps them to understand that it's pretty severe when if I tell them I've experienced this for, the last week, or it's been most of the time over the course of the last month, it lets them know that the fatigue is overwhelming and I'm really just stressed out about it.
Do you sense they want to hear about this?
No, I can't say that they do, because they can't fix it. And I think a lot of times they feel like it's synonymous with the disease and we just have to live with it. And I think that, as Melissa had expressed before, it's difficult explaining to people how we feel when we look a certain way. So they expect us to not feel as miserable as we actually are. And so we look okay. And so are we really that fatigued? Or are we just as fatigued like they would be at the end of a workday? They don't really understand that we feel horrible. So, no, I don't think they want to hear about it.
You've hit on something important there, which is they may feel a little helpless about fixing it.
Yes,
in quotes.
I agree.
And that therefore that's something they can't fix. They may not be as curious about or wanting to ask questions about.
Yes.
And as something they can fix, like
Right.
a swollen joint in front of you or a dactylitic finger or something like that. Melissa, do you want to add any comments?
I think I can just echo, what Minnie shared. Similarly, I've not been asked much about my fatigue. I've used kind of descriptors to talk about what that experience feels like for me. But, as you're saying, it's very difficult to feel like there's an actionable treatment for it. So usually I'm met with a response from the physician, like, well, we'll try this medication for your pain and hopefully the fatigue improves as well. And that's a little bit disheartening, and I think kind of contributes to the feelings that patients have about stigma and fatigue.
Right. Ernest, I was struck by the similarity in our presentations from the beginning to the end in terms of neurophysiology assessment. You did a better job at talking about treatment than I did. I just would say all the drugs that we've come to rely on for treating our diseases are effective, and it's similar to the forest plot that you showed for fatigue. For fibro, there's an expanded group of things, but also a lot of non-medications. I'm really interested if at some time in the future, 15, 20 years from now, we're going to be in a kind of Star Trek medical office, and there's going to be a little scanner off in a side room there that you just go and lie in, and we're going to have all the brain neuroimaging that you could want to tell us about what the nature of pain is or the nature of fatigue. Are you imagining that the scans are going to look pretty similar between the two? Or are there going to be some important differences? And do you think that that's at all that scenario is in our future?
That is a great question. So, okay. So one thing we have definitely learned over the last, I would say 10 years with really, really advanced scanner is that the brain don't work in regions of isolation. So when we first started research in scanner, we think of area in the brain that get active when we experience pain, or area of the brain that get active if we are trying to do certain tasks. Now, what is now clear is that the brain works a lot like a computer. They don't operate in single regions, and they are completely linked up together. And with scanners that take extremely fast pictures, we are now able to see that the different regions of the brain are linking together. And I've taught my students that if you think about when someone experiences an acute pain, what the different part of the brain get activated, which reflects on our pain experience. I'll use an example of how brain connect together and why therefore pain and fatigue and sleep are all linked together. So when we experience a peripheral stimulus of the brain, our sensory cortex light up, and it lights up to tell us where that stimulus is coming from. And if the activity get a lot more severe, then the hypothalamic pituitary adrenal axis get light up, which means that we are starting to feel stress as a result of the pain. And we get our blood pressure goes up, our pulse rate goes up, and the whole sensitivity of the person get lower because you're responding to this pain. It then also goes to the posterior insular cortex with drive emotional change. You start to feel dislike and feel unpleasant. So the first instinct you have when you experience pain is, I need to get rid of the pain. So you're avoiding anything that can cause pain. And that's important because this is protective. This instinct of the stress and the emotion is what protects you from the pain, because it instinctively tries to get you away from something that is giving you harm. But then once you started off that process, it has a cognitive element. The brain starts to try to interpret what this brain is coming from and start to respond to it. So there are circumstances where you can activate more your descending pathway to control the pain. And it happens every day when a patient come in and have a blood test. The needle is the same. The needle is exactly stimulated the same sharpness. But if you anticipate and have the cognitive control of the pain, you won't withdraw your arm. You control your distress. So that whole circle explains the acute pain experience. But I will say the problem is that acute pain experience is fundamentally important to allow pain to protect us from harm. But that is a very, very complicated pathway. And sleep actually helps to activate some of the descending pathway. If I deprive someone of sleep, then the descending pathway don't become as active. And when that happens, the circuitry rate changes. And that circuitry rate modifies the pain. So that's why pain is definitely not straightforward. That's why fatigue is definitely not straightforward. It involves different parts of the brain working together, coordinated in different fashion in order to produce the experience. And I think we just expressed everything that we talk about today reflect that complexity.
And we heard multiple times from Melissa and many about the fact that it's not easy to distinguish these phenomena. We sort of see them as discrete words on a symptom cloud: pain, fatigue, sleep disturbance. And we, as clinicians, we want to kind of put them in pigeonholes. But I'm hearing that it's not easy to do that, and sometimes they get all mushed together. And you're looking for approaches that will sort of modify or bring down the noxious aspects of each of these: sleep disturbance, depression, anxiety, fatigue, pain. They're very intertwined. And I'm learning and appreciating that more and more as I become an older clinician. Wow. So Melissa, can you imagine, you're going to be practicing medicine for many years to come. Can you imagine one of these scanners in your office or in your hospital complex? I think brain neuroimaging is going to have a pretty interesting future, personally.
Wouldn't that be wonderful? Yes, of course. I'm so excited to see how practice changes over the years. I think that's something that excites all of us about medicine, and probably a reason why we all are so fortunate to have this career path. Just always learning and changing. And I will say, just on that note, that's one thing I always wanted a physician to say to me as a patient that I've never really heard. And it's just to say, I don't know, but people are looking into this. There's research. And I think that's such a beautiful way to validate your patient's experience by saying, this is important. People are looking into it, but I can't help you right now. And I think that's maybe something I'll carry forward into my practice with patients.
Sure. Well, terrific. I'm so appreciative of each of you to participate in this discussion this evening. And for you, Ernest, what time is it now?
It's just after it's 1:30 in the morning.
Oh, well, okay. Good luck with your patients tomorrow.
You're welcome.
Or today for you.
Yeah.
And Minnie and Melissa, just really appreciate it. Let's go to the, if we could, the wind-up slides. This is just to say that we are going to be having a podcast based on the material that we've been presenting, and those will be released September 29th and at 27th and 29th. They will be two different podcasts, one that's clinician directed and one that's patient directed. And next slide, please. And then we have a patient-facing pain and fatigue webinar on October 5th. And then on October 19th, I'm sorry, I misspoke. This will be on treatment updates on October 5th, patient-facing, and October 19th, clinician-facing. And then on November 3rd, a patient-facing webinar led by Elaine Husney from the Cleveland Clinic. Does changing behaviors help your arthritis? Lifestyle myths and solutions. So we hope that if you all may be able to participate in these webinars and feel free to spread the word to either your fellow clinicians or patients about this. Next slide, please. We do need and request your evaluation. And in order to get CME certification, here are some instructions. And again, the QR code that you can use for that purpose. Next slide, please. And just to say thank you all for giving us your time today to learn more about various aspects of pain and fatigue and psoriatic arthritis and axial spondyloarthritis. And thanks to all these various patient and clinician organizations that are noted below: Spartan, GRAPPA, SAA, and the National Psoriasis Foundation, which are making this possible, along with a unrestricted educational grant from Pfizer. Thank you.